Next, we have Dr. Leila Madam talking on importance of extraocular movements in children. Over to you, Madam.
Morning. So now we come to the importance of looking at the extraocular movements. So examination of extraocular movements is important in a child who presents with squinting or an abnormal head posture. And in any child where they suspect an occasional squinting or occasional head posture, you have to look at the extraocular movements. It's not always possible to make them look in the extreme positions, especially vertical gaze positions in an infant. But observation as and when the child is brought in and looking during history taking and the doll's head movement usually help. And just to brush through the extraocular muscles, we have 6 muscles. We know superior oblique and lateral rectus are supplied by the single nerves, and third nerve supplies all the rest of the 4 muscles. Though there are 9 gaze positions, 6 diagnostic gaze positions test these specific muscles in their discrete action. Like we know superior rectus is up and out, inferior rectus down and out, and inferior oblique up and in, superior oblique down and in, and so on. So versions are binocular synchronous symmetrical movements of the eyes in the same direction, and ductions are uniocular movements examined when versions are not full, and vergence is synchronous movement in to the opposite side. In the opposite directions, inward is convergence and outward is divergence, and we can document them in a scale of -4 to +4 with underaction and overaction in an H pattern, and grading of overaction and underaction of inferior oblique and superior oblique when there is an upshoot, or what we call over elevation in adduction and over depression in adduction. And showing elevation and depression, there is a marked difference of showing B pattern or A pattern. This is important. And as already pointed out by Dr. Soumya, observe for an abnormal head posture. You can see this child showing, is there a pointer? That the child has a very subtle left head tilt, which when corrected only shows the hypertropia. You can see here. There is hardly any hypertropia here, but when corrected, we can see the hypertropia. So also the chin up posture, which when corrected, and there is a face turn to the right, you can see the eye goes out. There is a Brown syndrome left-sided, and this is a DRS child with the mild head face turn to the right. So versions are binocular pursuit movements. They are following movements, synchronous. Look for any asymmetry. You can, before using a cover test, you can just see the movements, and this is doing in subtle movement abnormalities. You have to do a cover test in all these gaze positions, diagnostic gaze positions, and document them. And the speed of movement is also important. This is versions. This child is actually looking at the, this is levo version, but the left eye is not moving because he has a cross fixation. As soon as the right eye is covered, this OK and drum, he is looking with the left eye. So now you know that duction is full. So this is another child with a, she has dextro version is full, but levo version is not. And you ask the parent to cover the left eye because sometimes they may not allow us to touch the face. So the father is covering the left eye, and then you can see the adduction is still not full. And you can also note that there is if there is a pseudotosis or not when covering the other eye. That is another useful information you get from cover test. This is vergence, convergence, and divergence can be tested by moving a fixating object. The saccades also, the speed of movement also has to be looked at. This is there is an upshoot, sudden abrupt stopping of the movement. There is a normal saccadic velocity is there, whereas this patient has a slow movement, which you can see a floating movement or floating saccade, as you can see. So this is a child as in a very young child because they keep the chin up and try not to look at, not to elevate the duction test that it is moving fully, but in restrictive strabismus there will be no movement, and this is a force generation test where you look at the generation of force generated by the medial rectus, whether to tackle the medial rectus at all. In a child, the force duction test may not be possible in office. You may have to do it under anesthesia when you plan for surgery. And this is a positive force duction test. In Brown syndrome, you can see this eye is moving up and in very freely. And you go to the other side, left side, there is no, there is marked restriction of movement up and in. Oh. So this is superior oblique traction test. When you suspect superior oblique palsy, you want to know the laxity of superior oblique. In V pattern, we must know whether there is an over elevation in adduction to see which muscle has to be tackled. This is a V pattern without inferior oblique overaction, where you will not tackle the inferior oblique, but displacement will be done. Here you can see downshoot in adduction in both eyes, and an A pattern. There is more than 45 degree when he is looking down. A pattern corrected after superior oblique posterior tenectomy is done. To summarize, testing extraocular muscles in children is an art and needs patience and examining again when necessary. And extreme positions may be checked by doll's head movement and specific tests in individual cases. Not all tests need to be done in every case. Thank you.
Thank you, madam. That was a wonderful talk on extraocular movements. I think the single most important test in a child with strabismus is the extraocular movements. Thank you, madam.